The topic I am going to discuss today is on IOL calculations following previous refractive surgery and intraocular surgery. When cataract surgery is performed on a patient who has had a previous refractive procedure, accurate keratometry readings are not obtainable by standard manual or automated keratometers. As we all know, refractive procedures flatten the central cornea. Keratometer mires are spread over a larger area and now measure approximately the central 4.5 millimeter of the cornea rather than the central 3 millimeter. Use of standard corneal measurements for IOL calculations results in an hyperopic post-operative refractive error. So this is one of the drawbacks which we find with the keratometers. Automated keratometers are usually more accurate than manual keratometers in corneas with a small optical zone, 3 millimeter, because automated keratometers sample a smaller central area of the cornea, that is nominally about 2.6 millimeters. Automated keratometry measurements following LASIK or PRK yield accurate measurements of the front radius of the cornea, because the transition areas are far outside the 2.6 millimeter zone that is measured. Using a formula where the patient's actual preoperative anterior chamber depth is entered into the calculation is probably the best, that is the optimized Hage's IOL constant formula and the Holiday 2 IOL consultant formula. And formulas that only take into account the axial length and keratometry, they falsely assume that these patients with such flat Ks must also have shallow anterior chamber depths, resulting in incorrect IOL powers. So for us the challenge is the post-operative keratometry, because radius of curvature is no longer spherical in them. Also, a 3 millimeter optical zone will not represent the effective corneal power, and the relationship between the anterior and the posterior corneal radius is altered. The radius of curvature tends to be steeper, and the power of the central cornea is overestimated while calculating with the keratometer. Hence, measurement of the K is not the actual K, and so to calculate the K, we have different methods, but the most common of them being the clinical history method, then the hard contact lens method, the average central power, the phase and Manises and modified Maloney's method, Masket method, and the double K method. So we will just find out the advantages of each of them and how useful they are in our day-to-day practice. The clinical history method we normally obtain if we have the pre-op K and the pre-LASIK refraction, then these two are very essential, and we convert the pre-LASIK refraction at the corneal plane. Also the post-LASIK refraction is converted to the corneal plane, and we derive the post-operative K, which is the K readings, which is pre-operative, plus the change in the refraction from the pre to the post-operative refraction what we get. Also, the formula to correct to the corneal plane is refractive R equal to R divided by 1 minus R into 0.012. So, if you look at this patient with a pre-op K of 46 diopters and a pre-op refraction of -7 diopters and a post-op refraction of -1 diopter, then you have the effective K as 40 diopters. It's very important that only if the pre-LASIK K and the pre-LASIK, post-LASIK refraction are known, that you go into these different steps. And you calculate the pre-LASIK spherical equivalent at the corneal plane from the spherical equivalent at the spectacle plane. And you convert it, and then you get the effective correction. So you have the second step where you have the change in the refraction, and then the mean post-op K is equal to the mean pre-op K that is found by keratometry, and the change in refraction at the corneal plane. So you find that it comes to almost about 36.85 diopters. So if we had a pre-LASIK K of 44 diopters with an axial length of 21.89, then the IOL would have been plus 25. However, if you see that after LASIK, if K would have been measured by the keratometry of 40 diopters, then and the axial length of 21.89, IOL to be put would have been 28.5 diopters. But the calculated K is 36.85 with the axial length of 21.89. So the IOL put comes to around 31.5 diopters. So that means that we would have underestimated the IOL power by 31.5 diopters to 28.5. That's about 3 diopters. So the history method has been shown to be not only very accurate in post-radial keratotomy patient, since the post-op refraction never completely stabilizes. So probably we cannot rely on this method for radial keratotomy. The second is the contact lens method of over-refraction, and it measures the change in the refraction with and without a rigid, hard contact lens. And as the base curve and power of the contact lens is known, the true curvature of the cornea can be calculated from these measurements. So the measured refraction, you convert it once again into the corneal plane, and you insert a contact lens of a known base curve and a power. And thereby this method is only reliable when there is minimal amount of cataract allowing you to do a precise refraction. Hence, if the current refraction, if it's only 0.25 diopters, and if the base curve of the hard lens is 35 diopters, hard contact lens, and the refraction with the hard contact lens is 2 diopters, then the change in the refraction would be minus 2.5 diopters. Thereby the mean corneal power would be base curve plus the change in the refraction, which comes to 32.75 diopters. The contact lens method, the principle is that if the refraction does not change on putting the hard contact lens of 0 power, the power of the cornea must be the same as the base curve of the contact lens. So if there is a hyperopic shift, the power of the contact lens would be less than the power of the cornea, and if there is a myopic shift, then the power of the contact lens would be more than the power of the cornea. So how do we reduce the inaccuracy of conventional keratometry? There has been numerous formulae which have been incorporated, and the formula recommended by Maloney and Kopp, where you have the Kc, which is equal to 1.14 into post-keratometry minus 6.8. So here we have Kc, which is the corrected mean corneal power, and the KPOST, which is the post-LASIK K readings. And you have a factor of 6.8, which is taken in this formula. And the K readings can be adjusted by a correction factor to adjust for the altered ratio of anterior and posterior corneal radius of curvature. Now these strategies are useful when no historical data is available. The formula recommended by Samuel Maskett again is a relationship that can be derived between the refractive error corrected by LASIK and a factor to adjust the lens power predicted using post-LASIK keratometry values. Here you have an IOL power adjustment wherein you have the total prior laser treatment adjusted for vertex distance into a factor of 0.326 plus 0.101. Of course, this requires the knowledge of the refractive status before and after refractive surgery. The most common and popular formula now is the Haig's-L formula for post-myopic LASIK patients. And here you use the IOL master corneal radius measured in millimeters. The Haig's-L algorithm generates a corneal radius, that is the R corrected radius of curvature, and which is used by the regular Haig's formula to calculate the IOL power. And you have these numbers which are incorporated, and this gives a fairly correct and accurate reading in most of the cases. So for IOL calculations, what we do is that we use the same Haig's formula, but there is the only difference being that in between the two is that the myopic version of the Haig's L first calculates a new corneal radius based on the myopic Haig's L algorithm. The other method is the Feast-Mannis method, wherein the IOL power is calculated using the pre-LASIK keratometry. And there is no special formula correction that needs to be employed. But this calculated pre-LASIK IOL power is then increased by an amount of refractive change at the spectral plane divided by 0.7. So here you have the pre-IOL power, and then you have the power of the IOL using the pre-LASIK keratometry divided by a factor of 0.7. And this also is a fairly accurate formula. In cases of post-hyperopic LASIK and in RK, the effective refractive power of the Pentacam and the Zeiss-Humphrey topographer works very well. Hence, in conclusion, to calculate the K, if the K and the refraction are known, then clinical history method still works very well. If K is known but the refraction, pre-op refraction is not known, with a visual acuity of more than 624, where there is still a cataract is not yet developed, then a hard contact lens method is still very good. And if K and R both are not known, and if the visual acuity is less than 6/24, you can take the average central corneal power readings and do the measurements. If the refractive error is hyperopic, then the double keratometry method or the modified SRKT formula is very useful. And the third generation formulas, also like the Hofer Q, Holiday 2 and the SRKT, Haig's formulas are also very useful. Some of the other methods which I would like to add is the intraocular retinoscopy, handheld autorefractometry, and the secondary IOL implantation, wherein you could do this if at all you find that the other formulae do not work. Thank you very much.